that they've shown in the research, if people have these conditions, they typically do better. If they have these conditions, they have a more difficult time recovering. So some of the things that predict success is your pre-morbid level of activity. If you have a quite active activity, you do things, you participate in social groups, you go out and do golfing or walk around the shopping center, typically these people do a little better than those that have been, bed bound for an extended period of time or really just reside in the house and don't go out into the community. Having a good, normal, healthy health status. BMI just means a ratio of your height to your weight. So people that are qualifying in the obesity or morbidly obese category have a little bit harder time recovering because there's more weight on this joint that's just been replaced. So being healthy, non-smokers, smoking definitely affects the healing process. People that smoke take longer to heal. Smoking cessation should be a part of any type of pre-surgical consultation. Keeping a positive attitude, that sounds kind of cliche, but it really does, and the studies show that people who have a positive perception of their health and a positive outlook on their recovery tend to do better. Effective pain control, of course. If you're in pain all the time, you're not going to want to come see me and have me bend your knee. So using the prescription medication, using the ice, using distracting things. Oftentimes on the first day I'll do an evaluation of a patient and they'll tell me, I'm not taking the pain meds, I don't need those. And I respect that. If you don't want to take the pain medication, that's fine. But if it gets to a point where it begins to hinder your progress in therapy, that's when we need to think about maybe you should take that pain medication so you can more effectively participate in physical therapy. And of course, that's something that you talk to your doctor about as far as prescription pain medication. And then we'll kind of speak on the next slide about having some physical therapy before surgery. Some things that can hinder your success. Most of them are comorbidities or things that you have going along in your body. So if you are overweight, if you are a smoker, if you consume frequent alcohol, if you have diabetes that delays the healing process, a sedentary lifestyle, like I said, if you just really don't do much activity, those things can slow down your progress, okay? Again, the other side of the argument is have a negative perception of your health and just overall being non-compliant with physical therapy. Typically on the first day, we'll examine you, we'll give you a home exercise program, or even way before that in the hospital, they'll show you things you need to be doing. If you're not doing those things, you're not going to make as good of progress as you could had you done those things. So this is an interesting study that just came out and was published in the Journal of Bone and Joint Surgery, and then the physical therapy centers picked it up. So what this study looked at is people that received a short course or a consultation of physical therapy before their surgery had better outcomes and decreased cost associated with physical therapy. I think the average number of sessions, they did an evaluation and then maybe 1 or 2 treatments, costing about $100 was the average. But what you look and see the savings are, on average, you reduce post-op care by about 30%, which is an average of $1,200 of savings. So just having that one time sitting down with a therapist, letting you know what your goals are going to be, how you can work on your range of motion and your strength before surgery, really helps with outcomes on the other end of the surgery. There's an interesting fact there. 54% of the people that had prehab or rehab before surgery required therapy after, versus the people that didn't have any sort of pre-surgical consultation, 79, almost 80% of them needed surgery or needed rehab after surgery. So it just goes and highlights the point that a short course of physical therapy before surgery is very, very beneficial, both physically and financially. And that should be a big part to consider. So we'll kind of take you from the minute they finish surgery to the next day. Like Dr. Athans said, typically within 24 to 48 hours, there's going to be a physical therapist knocking on your hospital door saying, you want to walk? You want to try walking? Again, that's once the doctor's cleared them, they feel that they're appropriate for walking. Like we said, that nerve might still be a little bit weak, the muscle might be a little bit weak. We have to put a long leg immobilizer on you, show you how to use crutches or a rolling walker or a cane, just depending on what your weight bearing tolerance is, what your pain levels are, how bad your swelling is. Day one, we might just get you from the bed to the toilet and back to the bed, but that's a big achievement. We've regained your independence there so that now when you need to use the restroom, you don't have to call the nurse. You can kind of go there safely. Working on range of motion and strengthening. CPM machine, that just means continuous passive motion. That's the thing that Dr. Athans spoke about briefly. It's a machine that your leg is supported in. There's some straps, and basically what it does, it gently bends and extends your leg, bends and extends your leg. What a lot of the research now is showing is that the outcomes of people that receive a CPM in the hospital versus those that do not are really no different. There's no significant difference. It might feel a little bit better. It might be easier on the physical therapist because you're not as fearful of having the knee bend because this machine's been doing it. But down the road, 12 to 15 weeks, when we look at these patients, they all achieve basically the same number of degrees of motion. Yes, sir?
A question for you, maybe, Dr. Athans.
Absolutely.
Is this a 2-day hospitalization, outpatient? Does it?
And we're not there
Which way do they go?
as far as it being outpatient procedure yet, although we're leaning a little more towards it. In my opinion, it's not an outpatient surgery.
So you're what,
Usually
2
it
days?
takes, at the earliest for some people, 2 days. Most people, 3 days.
Really?
Yeah, 2 to 3 days on average. And there's a lot of variables that go into it. Where do you need to go home to? And like Dr. Athans said, I mean, we live in Florida, so most of us only have 1-story, 2-story houses. If you're up in New York and you're on a 4th floor walk-up, well, of course you're not going to be able to walk up all the stairs, so you might have to do a short course in either an assisted or a nursing home or an inpatient rehab center or something like that. So your length of stay is variable, but like you said, three days is average for us. By then, we're kind of looking to see where your next location is going to be.
What kind of anesthesia do you have?
Excuse me?
Your anesthesia, what kind of
Anesthesia.
That is not my domain. I'll let.
It's all general anesthesia for a couple different reasons. One is it's under a procedure for a while, so you want to make sure that you're safe and that you're going to have the tube there to help you breathe. For another reason, I want you relaxed. I don't want you fighting me during the surgery. Your muscles need to be very loose so we can do everything we need to do, and that's only something you can really get under general anesthesia. But like I said, we combine that with the nerve block and with the local injections and kind of local numbing as well for after the surgery. Yes, ma'am.
Absolutely. So after the hospital, typically the average patient does go home. Again, some may need to go to inpatient rehab, but we'll say in the perfect scheme, you go home. You might do a short course of in-home physical therapy. That's where a therapist comes to your house 1 to 2, possibly 3 times a week, works on improving your mobility, getting you walking around the kitchen. If your bedroom's on the 2nd floor, they may teach you how to walk up and down stairs safely, just general mobility things. Ultimately, the final goal is to get you into some outpatient physical therapy, which is the domain that I work in. Typically on your first day, you'll be seen for about an hour. We do an initial evaluation where I'm measuring your range of motion, seeing how much progress you've made in the hospital and home health. Based on your deficits of your range of motion and your strength, we'll give you a list of exercises you could start doing immediately. It's very important that you're compliant with those. Again, the more that you do them on your own, the better your outcomes will be.
Can you overdo?
You can overdo, absolutely. That's a great question. Oftentimes I tell people to do the range of motion stretching exercises 2 to 3 times a day. When it comes to strengthening, we need to be a little more weary on that. If you're constantly pushing the knee, not giving it time to recover, not using ice to control inflammation after that, yes, you can absolutely overdo it. And that's where your relationship with your physical therapist comes in, is we kind of reassess you each time we see you. We may not do a full evaluation, but we're watching you walk. We're asking you your pain score, how bad it is. We should see those pain scores hopefully going down. If they're going up, that means that physical therapy in your home program might be a little too much. We need to pull back on one of those. That's a great question, absolutely. You can't overdo it. Primary treatments, exercise, activity, gait training. Again, that just means teaching you how to walk. Manual therapies where myself or someone else will manipulate the knee, physically bend it, straighten it, make sure that kneecap is moving up and down, gliding appropriately, even working down at the ankle and the hip. Modalities just means things that control pain and swelling. That's ice, electrical stimulation, heat in the later course of things. But we try not to do too much of that here because most of those things can be done on your own at home using ice. Whereas the other things, the exercise, the manual therapy, those are the things that are really going to make the difference. Average outpatient physical therapy for a total knee replacement, anywhere from a month to 2 months long. That's at a frequency of 2 to 3 times a week. And again, that just is based on if you have other comorbidities, it might take you a little bit longer. So, don't really need to speak too much about this. Dr. Athans covered most of this. Total knee replacements are primarily indicated when you have severe osteoarthritis. Conservative treatment has failed, the injections have been exhausted, pain management isn't cutting it anymore, you're not being able to get up, you're sacrificing quality of life because this knee is limiting you so bad. That's typically when we go to surgery. There are multiple types, like the doctor said. There's a unicompartmental, a bicompartmental, but oftentimes what our experience with is a total knee replacement. There are those rare occurrences where someone falls on the kneecap and breaks the kneecap, or has a motor vehicle collision and they just need one compartment, but they're very rare. I haven't seen any here. This was an interesting figure that I found. I don't know if it's our lifestyle that we're living, but the projected increase from 2005 to 2030 in the patients that are going to require total knee arthroplasties is about 637% increase in patients. So that's an extra 3.5 million more patients by the year 2030 that are going to be requiring knee replacements. It's multifactorial. One can make an argument that we're living longer, so the knee is wearing out later in life. All kinds of variables. I don't want to get into those things. So I already kind of talked about this. Day one post-op, bending the knee, moving around in bed, perhaps a CPM machine. But really your goal is to be discharged from the hospital. These are the things that we look at. Are you able to get in and out of bed? Are you able to walk 25 feet on your own with some sort of assistive device? Are you able to achieve 90 degrees of knee bending? And are you compliant with your home exercise program? If we could say yes to all of those and you have a safe home environment, then we typically try to get you home. Your therapist in the hospital will decide any things that you need, like a shower chair or maybe a leg lifter if your leg is very weak. It's just basically a strap you can help lift your leg with. But all those things are taken care of by the social worker, the physical therapist, the occupational therapist that you work with in the hospital. Here's kind of a typical progression, 0 to 3 months of physical therapy. The first 6 weeks isn't really here. That's the part when you're in the hospital at home. 6 to 12 weeks is typically when we get them. Sometimes we get people even earlier than that. But I think I already spoke about most of these things, so we can move on. Hip replacements, unless anybody is interested in that, I was planning on just kind of skipping past that. Anybody having a hip replacement? Good. Again, total shoulders. These are just all kinds of joint replacements that we service here at home in therapy. Good. So basically, just to summarize, the take-home message is physical therapy should be a mainstay after any type of joint replacement surgery. Initiating physical therapy before your surgery, just coming for that consultation, learning things you need to do, how you need to modify your lifestyle, will greatly decrease the cost after surgery and even decrease the burden of you having to come to therapy after surgery. As Dr. Athans said, he's got the easy part. You guys have the hard part. He's going to put a brand new knee in there and it's, pristine. There's other things that we have to work on after that. We have to get that range of motion. We have to get that strength. So that's where physical therapy comes in to help you get back to do the things that you wanted to. And again, the average length of outpatient therapy, 2 to 3 times a week for 4 to 6 weeks, varies just depending on other factors. And I think that's all I have.